This episode of The Poison Lab is supported by Pre-NK.
Are your door-to-needle times dragging? Too much time spent thinking about whether it's a stroke instead of sharing the gift of thrombolytics with anyone brave enough to present symptoms? That's why we invented Pre-NK, the world's first ever clot-busting lytic for anything you think could be, might be, or feels spiritually like a stroke.
Your patient Googled that smelling burnt toast can be a sign of a stroke and presented because they were cooking toast. Better play it safe. Pre-NK.
Your patient is GCS3 after massive head trauma from an MVC. How can you rule out that a stroke didn't cause the MVC? Better grab that Pre-NK.
Your patient read that atrial fibrillation increases stroke risk. They don't have atrial fibrillation, but their mom does. Hey, don't delay. Pre-NK.
Patient is complaining of back pain on one side but had a stroke 6 years ago? Who's to know? Maybe it's a backstroke. Don't take the chance. Pre-NK. Stop letting nerds prevent you from giving the gift of thrombolysis by asking for things like CT scans with dangerous radiation. Ask your drug rep today about the incredible power of Pre-NK, now available in topical, paste, and spritzer bottle form.
When time is brain and certainty is optional. One mist, one miracle. Pre-NK. Note, no data currently exists to support the evidence of this medical device, but your DTN will go down, and your administrators will be happy. Not FDA approved, not FDA reviewed, or even FDA adjacent.
Hey everybody, you are listening to The Poison Lab, a show about poisoning from people who manage poisoning. I'm your host, clinical toxicologist and emergency medicine pharmacist Ryan, and oh boy, do we have a fantastic episode for you today. We have a mix of Stump the Toxicologist, questions from reddit.com/askdrugs, and of course, your listener guesses we're going to get to go through for the mystery case that we released prior to this episode. And all of this is going to be co-hosted with an incredible medical toxicologist, Dr. Damilola Idowu Ellsworth, who, in addition to being a fantastic toxicologist, is also the current chair of the acute intensive care section of the North American Congress of Clinical Toxicology. And on top of all that is one of the colleagues I get to work with on a regular basis. The kind of person where you're just like, yes, they're on today. This is going to be a great day. And I am thrilled to have them on this show today. I should have done it a lot sooner. In fact, some of you might recognize her voice, either as the previous champion of the clinical pathology competition at NACCT, where she correctly diagnosed ibogaine poisoning out of left field, wild, or you might recognize her from one of our bonus episodes if you're a supporting member. She was on the NACCT Stump the Toxicologist Train episode and did a fantastic job there. So I'm thrilled to have her on the show today. Now, we'll kick off the show going through listener guesses as to what our mystery case was. And if you haven't heard it yet, I'm going to play it for you in just a moment so you can start developing your own differential. Then we're going to jump into some Stump the Toxicologist. We have 4 fantastic cases with a lot of great learning from each one, and cover a couple of listener questions and questions from the internet. We touch on a lot of topics: the ails of dodging drug tests, rodenticide problems, one of the most poisonous substances known to man that you probably have never heard of, why nobody knows what to call their Xanax, and so much more. I really had a lot of fun on this episode, and I hope you enjoy listening. And my absolute favorite part, one of the lucky listener winners is getting a copy of Poisonous Fungus Among Us Edition 1. And Poisonous Fungus Among Us Edition 2 is actually already out on Amazon right now. It has been updated with some gorgeous photos from amazing mycology experts at the Wisconsin Mycological Society. I have worked on a lot of different projects, and I'm pretty sure this silly children's book is the favorite thing I've ever done. So thank you so much to everyone who actually went out and got a copy and has read it to your children and told me that they loved it, or has told me how much they themselves learned while reading a silly children's book. I have decided that this is the peak of educational material that I will ever make. And thank you to everyone who helped support me in actually doing this. If you bought a copy of Edition 1, I want you to know I could not have done Edition 2 without your support. Thank you so much. Okay, enough of me blathering. We're going to jump into the mystery case as well as the disclaimers before the show. But like always, if you want to jump straight into cases, check the show notes. I will put a timestamp for when Dami and I dive into some fantastic tox cases. For everyone else, take a listen to our mystery case and see if you can come up with what was the cause of this toxic syndrome. Toxo, roll the clip. It's a Saturday, and a young, otherwise healthy male comes to an urgent care with cough and chest tightness. He's got no past medical history, and the symptoms started suddenly this morning. He was fine at work the day before. He's got no fever or oxygen requirement, his x-ray is fine, and he's discharged with a viral syndrome. Over the next 48 hours, however, everything changes. He returns to an emergency department with altered mental status. He's confused, and he now has a high fever, an oxygen requirement, and bilateral infiltrates on his x-ray. The admitting team starts him on antibiotics, but notes something very peculiar. His occupation is listed as a waste treatment plant worker, and this is the fourth waste treatment plant worker they've admitted in the last 2 days. One of them has already died. Over the next day, the patient rapidly crashes, requiring intubation. He goes on to develop pulmonary hemorrhage and a pneumothorax, and things don't look great for the other workers. Extensive infectious workup is performed, and it is all negative. Could a poisonous exposure link this group of young, healthy workers, all with altered mental status, chills, fever, and catastrophic lung injury? You're about to find out. But before we dive in, our standard disclaimers. On this show, we discuss real poisoning cases and answer real questions posted by people on the internet, often asking about how to use illicit drugs or why those illicit drugs are causing them harm. While this lets us explore important toxicology concepts, we are not advocating for illicit drug use. Using illegal or unregulated drugs carries many risks, including potential toxic contaminants, toxicity from the drug itself, and overdose risk from unpredictable concentrations between batches. If you are struggling with substance use, help is available. Call 1-800-662-4357 to reach the SAMHSA free substance use helpline and get the help you deserve. We also discuss real poisoning deaths in this show, including cases of intentional self-harm. If you or someone you love is struggling with thoughts of suicide, please call or text 988, the National Suicide and Crisis Lifeline. Someone is there to listen. And we discuss these cases in a clinical and educational way, and that can sometimes sound emotionally detached. It's an occupational hazard of working in healthcare. We may also joke or even laugh at times while discussing fatal cases of poisoning. That humor is never about the patient or the harm. It's about the science, the misinformation, or the sheer weirdness of toxicology. It is a coping mechanism and not a lack of respect. These were real people, and the reason we talk about these cases is to help the next patient have a better outcome. Their lives, stories, and loss matter. Listener discretion is advised. Finally, this podcast is for educational purposes only. And while we will discuss the identification and management of poisonings, this is not medical advice. If you think you are being poisoned or just have general questions about poisoning management, medication mix-ups, drug interactions, household cleaners, plants, mushrooms, snakes, radiation, chemical spills, or just something that feels off, call your local poison center, where you will get 100% free medical advice from trained toxicology experts. So don't fret. You're not alone. You only need to pick up the phone. The help is free, and the expert's true. They will know what's best to do. You just call 1-800-222-1222. Okay, without further ado, let's get on with the show. Hey everybody, you are listening to The Poison Lab, and today we have an incredible guest with us. We used to call her the fellowship breaker because every once in a while you get a fellow that's so good you think no one will ever be able to replace them. Fortunately, we have had some incredible fellows after them, but our very first fellow to ever go through the Wisconsin Medical Toxicology program is here with us today, and I could not be more excited. Dr. Damilola Idowu Ellsworth, welcome to the show.
I'm really glad to be here, Ryan. Thank you for the invite. I have been waiting for this for a long time to finally get the opportunity to be on the show. But yeah, I'm Dami. Most people call me Dami. I'm one of the medical toxicologists at Medical College of Wisconsin. I'm the assistant program director of the fellowship. And so just a quick plug for our fellowship. I stayed on as faculty after graduating. And so it just kind of speaks to how much I love this program and love the people at the Medical College of Wisconsin.
I appreciate that. And I love the people at the Medical College of Wisconsin. Double endorsement. Dami was, I got to meet you as a fellow, and I can't even believe I got to have that opportunity, because seeing how you are now and what you do now is so fantastic. So it's really cool when you get to see someone as a trainee who, is later just going to run the world. It's a good thing. So you are a medical toxicologist at our facility in Wisconsin. I like to refer to you as the queen of bupropion, from some of your fantastic research looking at time to heart rate elevation and prediction of seizures. Really helped us out with a lot of triage. And I also refer to you a lot, I don't know if this is the right term, but the lead czar of Milwaukee. I don't think you want to be a czar. I don't know if that's a good term, but I know that you have done an incredible amount of work to help get lead poisoned patients treated in more humane ways, where they don't have to be stuck in hospitals for, days getting their bowels cleaned out. I know, listeners, this might sound crazy, but that is what happens in a lot of scenarios. I'm thrilled to have you on the show, and thank you for joining.
Thanks for the invitation.
Before we get into things, so listeners, we got a lot packed into the show. We got a guest we got to get through. Then we're going to do some Stump the Talks and maybe some questions from the internet if we have time. But I would really love to hear Dr. Idowu Ellsworth's perspective on why she got into tox in the first place.
So toxicology is one of those things where you have the opportunity to truly nerd out while also having the opportunity to make key differences. And so while I was going through my emergency medicine residency, I knew that I wanted more, and I wanted to go back to a lot of those biochemistry concepts. And a lot of the people who trained me in emergency medicine, shout out to the folks at NYU. I had some great mentors in toxicology, and they just kind of really facilitated that interest in me. And I haven't looked back since.
And we're glad, because that meant you showed up at our door. And now you get to help train the next generation of toxicologists as well. Also, second plug, I should probably mention, are you a non-physician looking to pursue toxicology? Because we are probably starting a fellowship here as well for a clinical toxicology fellowship. So if you're a pharmacist who's interested in learning about the world of tox, keep your eyes and ears open, because, well, we might be recruiting soon. So if you want to work with great people like Dr. Damilola Idowu Ellsworth, like myself, like a lot of our past guests, Dr. Matt Stanton, Dr. Jill Feeble, Dr. Amy Zosel, Dr. Justin Corcoran, Dr. Andrew Farkas. You can even go back and listen to the episodes to get an idea of how much fun they would be to get to work with for 2 years. Keep your eyes and ears open. All right. I already told Dr. Idowu that I have woken up late today and was way behind on what I was supposed to do for this episode. Do you ever wake up and then you can't go back to sleep, but you're like, well, I haven't gotten enough sleep, so I definitely need to
just lay here.
I need to lay here. And then eventually you do fall back asleep after 40 minutes. And then once you do fall back asleep, you slept way past where you're supposed to.
Yeah. It's the absolute worst. It's like your brain is just completely playing tricks on you. Just do what I need you to do.
Yes. That's what I tell my brain all the time. So that's where I started this morning. But okay, enough chatter. Let's just dive in totally unprepared. I think that's the best way. So we had a case. Now, I played the prompt at the beginning of this episode, so the listeners have all heard it and hopefully have come up with a differential, but I'll summarize it here for everyone in case they didn't listen at the beginning of the episode, and you can start to come up with some ideas yourself. So we had 4 workers from a waste treatment plant show up with fever, shortness of breath, pleuritic chest pain, and then eventually progress to life-threatening illness for a few of them. What's interesting here is they all work at the same place. You think about fever, pleuritic chest pain, and people in a small unit. You think of, infectious workup, but everybody was completely negative from an infection standpoint. So that leads you down the road of, well, is this maybe some kind of an occupational exposure? And the main symptoms we saw here were severe lung injury, and it was delayed. It happened about a day after exposure because the person came in on a Saturday and their last day at work was Friday. And listeners, I want you to know that Dami chose the case. So if it was a stumper, this is her fault. And it was hard. I don't think I would have come to the conclusion had I not had some prior knowledge of what the actual substance was, because there's a fair amount of possibilities in this one. And I will let you know, Dami, that someone did get it right.
Oh, amazing.
And I'm really excited because the listener winner for this episode is actually going to get a signed copy of Poisonous Fungus Among Us Edition 1. For the listeners, that is the Poisonous Mushroom Children's Book. So hopefully the listener winner has a child themselves or will know someone that they want to give it. But I do think there's something to learn from reading the book for even adults too. So let's dive into our emails. Young kids, delayed toxicity, severe pulmonary injury, and fatal for some of them. So let's take a dive into what people think this could be. This first guess is coming from listener Ashley M. She says, "Hello, I'm not a doctor, a toxicological, or anyone in the medical field. Toxicological, I like this. So while this guess is based on some research, it is only the research of a layman. That said, my hypothesis is some form of organophosphate poisoning, exact type, unknown. Reasoning. OPs can be found in a variety of different products, including herbicides and pesticides. And I can easily see someone choosing to dump those into the waste cycle instead of disposing of them properly, either out of ignorance or because of money. No source, just my own assumptions." Good thought, Ashley. There is always this organophosphates are obviously used in a lot of farming, and there's a lot of discussion about the runoff from farming
Right.
and contaminating, water tributaries and things like that. So maybe getting into waste from there. Ashley's next point says, OP poisoning can cause the original breathing issues noted. Okay. Other neurologic issues may occur, such as psychosis, memory loss, anxiety, and confusion, which may explain his altered mental status. Okay. Multiple other possibilities exist for the same constellation of symptoms, explaining why the doctors had a harsh time understanding it wasn't an illness. I think she means an infectious illness. I admittedly had a hard time determining the exact time frame for how long it takes for OP poisoning to develop. It's possible that this is due to my lack of access to medical journals, or I'm just bad at researching. I don't think so. It is
Not giving enough credit to themselves, this listener.
I know. This is a really interesting take they have. First off, why are any medical journals paywalled in the first place? It drives me nuts. But because they need to make billions off of the volunteer efforts of medical workers who just want to make care better. But that's fine. Anyways, I say this as a journal editor for but I don't get to decide whether they publish things for free. Anyways, Ashley goes on to say, I did find in my second source a note about a complication called intermediate syndrome. This syndrome typically occurs 24 to 96 hours after the onset of organophosphate poisoning and after the cholinergic crisis has ended. Patients experience proximal muscle weakness and cranial nerve palsy, which can progress to respiratory failure. This would theoretically fit in the timeline of the person not crashing until the day after work. I also looked into the chemicals used in cleaning a waste treatment facility, and to me, it looks like most of those would have a more immediate effect, not something that would get worse even after he was away from the source. Thank you, Ashley. P.S. Have you ever heard of the book Burton Rouchet? I have not. Have you heard of that, Dami?
Oh, I've not heard of it.
He has a series of essays for The New Yorker and the medical mysteries of the time, 1954 to 1996. Ooh, that sounds good.
I would be very interested in this.
Yeah, I'm going to have to check this out, including some old poisoning cases that I find fascinating from a historical and medical standpoint. Well, thank you for the tip, Ashley. I'm going to check that out. So there's a lot to unpack in this one.
Yeah.
And they invoke some serious topics here, like organophosphate intermediate syndrome. And I will say, Ashley, fantastic job researching a difficult topic there. People have written a lot about it. As someone who could provide a little more insight, this is less likely to be the case because OPs don't generally cause this fever and multifocal lung injury that we saw here. They cause exactly what you said, which is organophosphate intermediate syndrome. You show up with a cholinergic crisis, and then about a couple days later, you just develop severe muscle weakness and you can't breathe anymore. But it's not a pulmonary failure. It's more of a pulmonary muscle failure. What do you think, Dami?
Yeah, that's exactly right, Ryan. The respiratory failure is more a manifestation of the neurologic failure that you'd see with OP poisoning. And also like the absence of those dumbbells symptoms initially kind of point away from OPs here. But I definitely think that you have an occupational exposure where multiple people are involved. This is a really good one to think about.
Yeah, absolutely. Yeah, dumbbells for the listeners, that's a mnemonic for the cholinergic crisis that you can see. And right, usually with OPs, it's like an intentional ingestion and they come in looking really, really sick. There is like a smaller scale exposure, like chronic exposure over time that might lead to more subaccult symptoms and then like organophosphate polyneuropathy. But I don't think we see that there. So great guess. I love the idea. Always think about contaminating water. But let's see what other people have to say. So this one is going to be for Dr. Dami. Do you want to take this one?
Yeah. So this is from listener Pamela Moore. So longtime listener who is guessing for the first time. So I'm guessing this patient inhaled cadmium while at work, most likely cadmium contaminated dust. The source of cadmium was likely batteries and other electronics that were thrown away. Inhalation of cadmium causes pneumonitis that could initially be confused with a viral upper respiratory tract infection, as there may not be significant findings on pulmonary physical exam or chest x-ray. Unfortunately, the pneumonitis frequently progresses to ARDS, and patients can die within 3 to 5 days. My only hesitation is the lack of any reported renal involvement, as cadmium exposure would also produce nephrotoxicity with proteinuria. She says she loves the podcast. Thanks. So also a really, really good guess here, this like metal fever associated with cadmium. I think metals puts us really on the right track here with this weird febrile illness that wasn't an infectious etiology initially. And I also agree with the thoughts about the lack of renal involvement making this kind of suspicious. What do you think, Ryan?
I think you can always tell when a medical toxicologist writes in. Fantastic guess, Dr. Moore. I love it. Honestly, this would have been my probably guess. So maybe it is this. Wait, I shouldn't give it away. This is really a good guess because metal fume fever, a lot of people know about. You get a welder is working with metal fumes and they develop a febrile illness over the week as they're continually exposed, and then it goes away over the weekend, and then it happens again. And largely it's a benign condition, but there are some exceptions, which would be cadmium. And I always remember this because I always think cadmium, you found a Cadbury egg. It's special. It's different. It's the stupidest way to remember something. But cadmium leads to life-threatening pulmonary toxicity that's delayed by several hours to days. So it's the one metal fume fever you should not ignore. I always think a great paper would be like toxic time bombs. Things where the exposure is you can really go wrong by mistriaging the exposure because a couple of days later they're going to die. And cadmium would be in that one. Fantastic guess, something that should absolutely be ruled out here. Okay, our next guest comes from Margaret Kennedy. She says, "Hi, I just wanted to reach out and thank you for the podcast. I'm an interested layperson and it's always fascinating. I'm mostly writing to thank you for your frequent mentions of the poison control hotline, My 8-week-old was accidentally given a dose of my cat's antibiotics this evening. Because of your podcast, I didn't panic or start Googling. I just called poison control. I love this so much. They were super helpful and let me know that a single cat-sized dose was no big deal. Fantastic. The information for your podcast directly prevented a lot of stress and fear. Thank you so much for all you do, Margaret Kent. Thank you, Margaret. Okay. I didn't realize that is not a guess, but that is also a great plug for the poison control hotline. I used to get a lot of calls about pet medicine. It's a really common thing that we run into, I feel like. And sometimes it's easy, but there are these antibiotics in the pet world that just don't exist in the human world. So I'm like, I don't know what that could do. And you have to scramble and try to figure out what's going on. Always an interesting time. Well, maybe since that wasn't a guess, I'm going to just steal this one right here.
Sure.
This one is from David Alcalay. He says, "Hi, Dr. Feldman. While someday I hope to work as a toxicologist, for now, I'm just an undergrad." Fantastic. Great start there, David. "I love your show and I've learned a lot from it and wanted to send in my guess and thought process. When I heard waste treatment plant, my immediate thought went to ammonia, which, if I'm not mistaken, is a pretty common toxic substance at these plants. That being said, I think ammonia would have been very noticeable and caused a much faster reaction." Excellent points to bring up there, David. Ammonia is a high solubility irritant, so you usually notice right away. As anyone knows who's been near ammonia, it stings the eyes and nose. He goes on to say, "So I find it hard to believe the person went to urgent care and got diagnosed with a virus." Okay. "I work as an EMT and have walked into houses with high ammonia due to animals and hoarding conditions." Oh boy, that sounds kind of terrifying. "And I've been able to tell and get out of there quite quickly, long before I was exposed long enough to get seriously sick." So David's bringing up really good points about what we call like canary signs. A lot of the irritants that can cause damage, like chlorine and ammonia, they actually are so irritating that they fortunately alert us and we're able to get out before the exposure is large enough to cause damage. So that's great. So then David says, "This makes me think of a few potential possibilities. I think because there wasn't a canary sign. If someone is dumping toxic substances illegally, that could have a downstream effect on the waste treatment plants. Workers, factories, illegally dumping. Absolutely. Anybody wants to look into the Minamata disaster in Japan? Although I don't know if that was the waste treatment facility, but that was dumping of mercury into the bay in Japan." So David says, "Maybe some home meth drug labs, but I think the byproducts of a meth lab would cause a toxidome similar to ammonia. So what progresses slowly but has such devastating effects? I Googled chemicals commonly used at a waste treatment plant, and a lot of them look pretty toxic, but most of them would have caused GI distress in addition to respiratory symptoms. Chlorine is one guess. Ferric chloride. Huh. Have you heard of that, Dom?
No.
I have not. Maybe I should. But these, like everything else I came across, should either cause severe respiratory burning if inhaled in large amounts, or very slowly cause symptoms if chronic low-dose exposure. I'm stumped. Sincerely, David. P.S. Your last collab with EMS 2020 was awesome. Your podcast and theirs are my two favorites, and you all do such a great job of teaching at a high level while still keeping the content accessible to people like me." Thank you, David. Seems like you would be an easy person to teach. I appreciate the email. Great guesses, and you brought up some great points. So he says ammonia or ferric chloride. I do think he's bringing up a good point here. Chlorine gas, although often called a high solubility, is actually intermediate solubility gas. So maybe there's
Yeah.
Maybe we've got a slight delay. I don't know. Good guess. Okay. Next up, you want to take this one, Dami?
Yeah. So this is from Jeff. "The waste treatment workers with severe lung injury ARDS symptoms and fever seem classic for hydrogen sulfide." I did have a hydrogen sulfide thought with our last listener talking about like pouring of substances in a sink inappropriately. So
Oh, yeah.
thought here. As a vet, that this is usually a big problem when there isn't proper hygiene practices on giant cattle farms where the sewage pools can release large amounts of this gas if they're stagnant for a while instead of having constant movement to break up the gases. They can get disturbed. And so this is a gas by hydrogen sulfide. I think this is also a good guess, but when I think about hydrogen sulfide, I think rapid decompensation. So that delayed decompensation kind of points away from that for me. So yeah, hydrogen sulfide is one where the canary effects for hydrogen sulfide is interesting, right? Because you get that olfactory fatigue really, really quickly. And so you enter, you sense something might be wrong, but the toxicity is so rapid. And so we think of it as a knockdown gas. And so another canary gets sent in, and then the same thing happens. That's kind of the classic story with hydrogen sulfide.
Yeah. Yeah. The delayed symptoms here, kind of unusual. Great guess. And it definitely, if you say the words, I mean, there's a couple buzzwords in tox that summon three gases every time. If you say the word hog farm, sewer, or manure pit, or waste treatment, like this is all you have to bring up. Hydrogen sulfide. Actually, carbon monoxide is often found in some of these hog farms. And then methane is a big product too. So you have a lot of gas potential toxins that you're dealing with. And hydrogen sulfide has been well known to cause a lot of collapses. So definitely, it's also a high solubility irritant. So you can get some conjunctival injection, all those problems. It's definitely the scariest one for a lot of these that I think about. Great guess. This next one comes from listener Kendall. They say, "Hi, Ryan, longtime listener, first-time emailer. I'm thrilled about all the first-time emailers. Great job, everybody. I typically only am with you about 75% of the show. I'm more focused on my molecular environmental toxicology in my graduate program, so I end up Googling a lot of medical stuff, even though there's a lot of base overlap. That's awesome. Well, thrilled to have you Googling along, Kendall. But as soon as I heard these symptoms, I knew maybe. My guess is the patient was exposed to phosgene. I love this guess. It has a soft hay grass-like odor, so it wouldn't have presented immediate concern to the patients or his workers, or his coworkers. They probably didn't even notice the smell. It has a delayed onset since it damages capillaries in the lungs over time, so it makes sense his symptoms are evolving. Unlike chlorine or ammonia, which would have done immediate damage. The fever seems like it's probably coming from chemical pneumonitis, which is a tricky mislead to get someone to think it might be something infectious rather than a chemical exposure. Very good. And I'm also thinking the altered mental state is from hypoxia, further indicating the blood oxygen barrier damage. Anyway, excited to hear the results. Thank you for everything you do, Kendall. Great guess, Kendall, and hitting on a possible delayed pulmonary toxicity. So you need a low solubility irritant, something that'll get into the lungs and not dissolve right away. So you won't get alerted and run away. And phosgene is a classic example of that. What do you think, Tommy? You think we got phosgene?
I think it's a great guess with that delayed decompensation and the fact that, again, we're talking about primary lung injury. And so I think we're on the right path for sure. And so this is from Rob and Rebecca, the Tox Lab. And so they say, hey, just seen the post on Reddit. It has to be hydrogen sulfide exposure, right?
Love it.
Another great guess, but as we established, that delayed effect is just not, it's just not convincing for hydrogen sulfide.
Yeah, but it is a great guess. And when I noticed they say Rob and Rebecca, the Tox Lab, and I was like, that sounds a lot like the Poison Lab. And I looked them up, and this is another Tox podcast. So way to go. I love seeing more Tox talk in the internet space. And I listened to an episode or two. Really great stuff, guys. Okay. Let's go on to number 8. This one comes from listener Kate Javes. It says, I initially misread the workplace as water treatment and immediately thought of chlorine, but those symptoms would not be delayed. The listeners are good. They know exactly what they should be looking for.
Things, yeah.
And the clinical course would have been different. I'm not very familiar with the various processes in a waste treatment plant, but I do know that incineration could be involved, and that could create some kind of airborne chemical hazard if the filters or air handler are not working properly. The clinical presentation sounded a little bit like popcorn lung, which we saw somewhat recently associated with vaping with less scrupulous manufacturers when they were using oil-based substrates in the vape fluid. Perhaps this could be something similar, although the exact chemical or mechanism is beyond me. Looking forward to the episode, Kate Javes, paramedic. I love the guess. Ketene. Ketene is a serious pulmonary toxicant that when vitamin E acetate is pyrolyzed, turns into ketene. So maybe if they are burning a bunch of vape cartridges that were contaminated with vitamin E acetate, they can make ketene. Fun guess. Okay. Oh, this is a great one.
Emily, a fellow night shift worker.
And one of our amazing specialists in poison information who nightly takes on the poisoning needs of the entire state and does a fantastic job.
So she says, okay, so it took me a while to think through this. I knew it was obviously some kind of inhalation exposure. And I remember from your SPY review on inhalation exposure that some inhalational exposures can look fine when they first present and then rapidly go downhill. I had to look into types of chemicals used in waste treatment. And after considering all of my options, my guess on the exposure is an occupational inhalational exposure to chlorine gas. Since it is only slightly soluble in water, it can take longer for effects to become apparent, all while it's doing damage to the lungs since it forms hypochlorous acid and hypochloric acid when it reacts with water in respiratory tissues. And that was the guess from M. So yeah, I think that M is just bringing up that point you made, Ryan, about chlorine gas. Really, we should think of as an intermediate soluble gas. And so you can have immediate symptoms that are very mild. And so a little bit of that noxious stimuli, and maybe you want to get out of there, but the effects can be delayed. In some cases, you can have really, really severe damage and, yes, progress to ARDS. So, yes, I think this is a really, really good guess from Night Shift Emily here.
Absolutely. Thank you for writing in, Emily. Appreciate that. All right. Our last guess comes from Kirk and Megan Fetters. Say, hi, Ryan. This case of a young, previously healthy waste treatment plant worker who developed sudden onset cough and chest tightness that progressed to confusion, fever, and chills and severe respiratory failure over the following days is yet another challenge that stretches our toxicology knowledge. I like that summary. I should have read that summary at the beginning of the case. He says the prominence of pulmonary symptoms with a suspected occupational exposure immediately brought pulmonary irritants and other dangerous gases to the front of our mind. However, common occupational exposures such as hydrogen sulfide, chlorine, chloramine, or even nitrogen dioxide did not fit well for various reasons. Fever is not well described as part of the toxidome of any of these cases, and the delayed phase of worsening could not be explained well, as far as we could find. However, we were able to find a strikingly similar syndrome reported with nickel carbonyl, which is characterized by sudden onset, mild upper respiratory symptoms with chest tightness, and a second delayed phase of much more severe respiratory illness a few days later, including sometimes a febrile illness without a pathogen identified. Occupational exposures are historically in oil refining, mining, and nuclear power sectors, but one case series was published about waste processing workers. Can't wait to find out the answer. Kirk Fetters, infectious diseases fellow, and Megan Fetters, an ICU pharmacist at University of Colorado. What a guess. And
what a great team there, actually.
Yeah, what a team. It's a lot of brain power there. Well, what do you think, Dami?
I think we've got our answer here.
Yes, I do. Okay, I do like to change little pieces of the cases that I pull so that people can't find them, but I didn't want to change the waste processing here because it was relevant to where the nickel carbonyl came from. And thus it maybe was a little easier to find. Great differential and reasoning there. They did a good job picking this one up. It was definitely challenging enough if only 1 of 10 people got it right. Fantastic. Congratulations, Kirk and Megan. Excellent guess on that one. So what are we dealing with here today, Dami?
Yeah, so we are talking about nickel carbonyl. And so this is a highly volatile organometallic compound. And so this forms when you take carbon monoxide and you react it with nickel.
As one does.
As one does. It's used in industries where you are trying to basically get this purified form of nickel. So nickel refining. And so it's part of something that they call the Mond process. And this happens when you take nickel, you react it with carbon monoxide, And that is what forms that nickel carbonyl gas. And then that gets broken down back into pure high grade nickel. So kind of think of it as this high tech filtration system. But its process is super, super dangerous as nickel carbonyl is very, very toxic. And so why would we take, all of this risk trying to get purified nickel? So nickel is one of those metals that it has really great physical properties that makes it come in handy in a lot of different industrial scenarios. It's hard, but also malleable, and it's really resistant to corrosion. And so, like a lot of metals, nickel has different forms of it. So it has the inorganic metallic forms, it has the organic form, as is nickel carbonyl. And usually when I think about nickel toxicity, I'm thinking about that contact dermatitis that you can get with dermal exposure. If you were to ingest a nickel salt, like a lot of metals, you will get that GI illness and distress. But that really appears to be self-limited according to case series where this happened. So you get sick to the stomach for a few days. You might get a little bit of renal injury, but that gets better.
Dami, when I was a kid, I swallowed a nickel once. That sounds a lot like what happened.
Yeah. What happened to you, Ryan?
I had a tummy ache, but then I got better. Okay.
That's exactly right. And that's because absorption is pretty limited in those metallic forms of nickel. And so you're not really getting a lot of systemic symptoms. With some nickel alloys, if you're like welding, you can get a metal fume fever, like we talked about earlier in the episode. And then for people who get chronically exposed to nickel, they can develop long-term pulmonary problems with like pneumoconiosis and pulmonary fibrosis. But
Yikes.
nickel carbonyl is the scariest way to be exposed to nickel because it's that organic form. It's very well absorbed. You can absorb it dermally, but the main route of exposure that we're typically talking about is inhalational. And so we've known about how toxic this thing is for centuries. And it's been compared to cyanide in some cases in terms of how deadly it is.
Like, why are we attaching I know why, but anytime you put 4 molecules of carbon monoxide on also a dangerous pulmonary irritant, you're not making things safer. That's for
It's
sure.
not a good time. Weirdly enough, the carbon monoxide is just kind of not the thing that causes
Right.
problems here.
Right. I know. It's just like a scary bystander, but
Yeah. And so, why is nickel carbonyl so dangerous? So one, it's super volatile, like we established. It's very able to penetrate membranes. And kind of like we saw in this case, warning signs are pretty limited. So it has a faint odor, but it's pretty mild. And then the symptoms can be delayed, like we established in this case. And in some case reports, symptoms are delayed as late as 1 week. So imagine you come in with a febrile illness, you seem like you're getting better, you get discharged, and then a week later you go into fulminant ARDS and respiratory failure. So scary stuff. Typically, we're talking about exposure in industrial settings. And so again, occupational exposures are really going to be the way that you get exposed to this. So you might come across them basically anywhere where nickel refining is taking place. So electronic manufacturing, some chemistry labs also may have access to this. But because it's super dangerous, it's under strict controls, it's highly regulated. And so exposure cases are quite rare, thankfully.
So on that, the case that we played for the show, this is a real case series out of Japan. For the listeners, I will put it in the show notes. And in this case, it was kind of an unusual place. We don't really think about it in waste management. But basically in this setting, there is a waste neutralization process that they used, which involved the use of high concentration of nickel and a complexing agent. And apparently, when they did an investigation of this plant to figure out why all these people got exposed to this nickel carbonyl, they found out they used an out-of-date complexing agent, which then basically combined with the nickel and released nickel carbonyl. So this was one of the scenarios where not all of the processes were up to code, and they basically combined nickel with the wrong chemical, and nickel carbonyl came out. Kind of an interesting one. But yeah.
That is interesting. That's part of probably why a lot of our listeners got stumped, along with this being a super rare
Yeah.
toxin.
There's a lot of red herrings here. If you say, like I said, waste management, it's always hydrogen sulfide or methane are big ones to think about. I think nickel carbonyl is terrifying, but it's in a way, it's also like there's this dichotomy in toxicology where you have like scary stuff and that you just shrug at because there's nothing I can do. And then you have scary stuff where there's like an incredibly amount of intensive things you need to do. And I
Right.
actually put this one more on the, oh no, you just told me about someone who's going to die I can't do anything for, than the, oh no, I'm going to do 1,000 things for this person. But there is one treatment that they talk about for this. Do you want to dive into that a little bit?
Yeah. So the reason that this isn't that category where you feel like you have a lot of options, Ryan, is because the evidence for the treatment that we do have is rather poor. But there are things that you can try. And so there is something called sodium diethyl dithiocarbamate, also called dithiocarbamate, which they have some animal studies where they took some rats, they exposed them to doses of nickel carbonyl that we know are lethal, and all of the rats that got administered this dithiocarbamate survived. But they noted that it really only worked well if they give it early. And so the rats that they gave it too late still ended up dying. There's some case series of patients that were treated with dithiocarbamate and seemed that it worked because a lot of them survived. Dithiocarbamate is not something that's going to be readily available in hospitals in the United States. And so there's another agent, disulfiram, which is actually broken down into two molecules of dithiocarbamate. And so this is another one that has been tried in some case reports and case series. And in some of those examples, patients did survive. There are other chelators that have been tried historically, like something called BAL, British anti-Lewisite, which is a really common chelator that we use for some other metals. But the data that we do have suggests that it's really
It,
not that effective.
it was a really common chelator we used
It
for other
was.
metals.
Yeah, I guess we
It,
don't really.
I believe 4 years ago, maybe, the sole manufacturer, Acorn Pharmaceuticals, stopped making it. So we don't even have dimercaprol anymore.
Yeah.
Hopefully no more Lewisite attacks that we have to anti-Lewisite. But yeah, I think this is fascinating because disulfiram gets broken down into dithiocarbamate. So what a win. Disulfiram is a super cheap drug. You know, you got to put it through their OG, probably, OG tube. But now you're going to get 2 molecules of dithiocarbamate. It seems low risk. Like, I would probably do it. Also, I find it really interesting looking at some of this old data. Randall Basalt. Do you know Basalt at all? It's like a famous textbook in toxicology it's called The Disposition of Drugs in Man, I think is the name of the book.
Oh, yeah. Mhm.
And it's written by Randall Basalt. And Randall Basalt, back here in 1977, did a study on different chelators in nickel carbonyl poisoned rats. So really interesting. I did not know that was work I know of Randall Basalt. I don't know the prior work he did. He unfortunately has passed away, so rest in peace. But interesting tie back there. So yeah, if you have someone who comes in with delayed symptoms, couple things on your differential, cadmium, nickel, delayed pulmonary symptoms, and you might be able to chelate some of them, which is great. And otherwise, it's just supportive cares and crossing your fingers. In this case series, 2 of the 7 exposed patients died, and none of them were chelated. But it is a scary one, and hopefully one that can be avoided with proper safety. Anyways, great job. That was a great review of nickel carbonyl. Such an interesting one, and one that you'll almost never hear about until you do, and then you're going to be like, oh, good, I'm glad I read about it that one time.
One time, right?
I almost forgot. The listener winner. So everybody had great guesses. So you can see I'm sharing my screen with Dami. Everyone had such great guesses that I am just going to do a random number generator. Okay. And we got it right here. Dami, can you read the number for me?
Okay, so we've got lucky winner number 6.
Okay, the 6th email that we got today was from Kendall. Kendall, the molecular environmental toxicology graduate student, congratulations. If you write in, send us your email, you are getting a signed first edition copy of Poisonous Fungus Among Us. Thank you, everyone, for writing in. They were really fantastic guesses and such an interesting toxin. But I think with that, it's time to move on to the next half of the show, which is going to be cases. Hey everyone, Ryan here, and I'm going to interrupt very briefly to let you know a few ways that you can support the Poison Lab. This show is completely free, and a lot of the educational projects connected to it, like our virtual resuscitation shock vasopressor game and all of our medical education lectures, are free too. But producing all of this actually costs money. Between domain name rights, website hosting, podcast hosting, which is a whole other cost, I know, total racket. Then add on annual website security certificates, subscriptions for audio editing software and hardware. There are actually quite a few behind the scenes expenses that go into making free educational content. So if you'd like to help support the show, you can head to thepoisonlab.com/support. For as little as $1 a month, you can help offset production costs, and you'll get something back. Supporting members get bonus episodes, ad-free episodes, so you don't have to listen to me right now interrupting you, timestamps for all topics discussed in the show. Now, there are a few other ways that you can support the show. If you want something real, tangible in your hands, check out some of our poisonous mushroom educational products. The second edition of Poisonous Fungus Among Us is out right now with beautiful photography from the Wisconsin Mycological Society, and it's honestly highly educational, a great introduction to mushroom anatomy and identification, or just a fun children's book. You can find that on Amazon.com. Just search Poisonous Fungus Among Us, one word. Then check out our Poisonous Mushroom card game, Gotta Pick 'em, now in its third version, with some updated photos, and we are constantly working on sourcing new photographs from around the world of all of these poisonous mushrooms to get the most beautiful pictures for this game. So there are updates that will continue to come out, and you can see which version we're at the website when you go to gottapick'em.com and click Buy Gotta Pick 'em. And guess what? If you don't know anything about poisonous mushrooms before buying the game, I can get you up to speed. I've released a full lecture about the 15 different classes of poisonous mushrooms, their toxic effects, and how we rule them in or out, all on gottapick'em.com. You can find it under the Learn the Mushroom section of the website. You can watch that lecture, which also ties in the toxic mechanisms of the mushroom into the gameplay mechanics, so that each time you play, you'll be reinforcing your understanding of these poisonous mushrooms. You can actually watch that right now for free and learn as much as you want about poisonous mushrooms without playing the game. I'm still actively looking for a publisher for the game. I am still actively looking for a producer to co-publish the game. Unfortunately, right now, the game comes from China, and the total cost with shipping, handling, and tariffs is about $50. I'm working as hard as I can to find a way to make that cheaper. I really don't make much money on that game, but the small amount I do make goes to supporting the cost of the show. And I'm primarily thrilled to see people practicing and learning the poisonous mushroom toxicrooms. So check those out if you're interested in those kinds of topics and you want to support the show. But if you don't want to spend any money at all, the easiest way to support this show is to share the show with a friend or leave a rating wherever you're listening. That really does make a difference in helping others find our messages about caring for poison patients. Okay, that's it. No matter how you choose to support the show, you're supporting it right now by being here, and thank you so much for being part of our community. That makes this show so much fun. Okay, let's get back to some toxicology. Questions. Now, Dami, I know that you know how to play Stump the Tox because you infamously stumped me with a doozy of a magnesium case while you were in fellowship, and it was so good.
That was insane.
It was so good that I actually used it on the very last episode of Toxicologist versus the Internet with Dr. Joe Kennedy, and he got stumped with it too. So it's a really tough one. And he is a bright toxicologist. So I think we're going to do a couple of cases here. Do you want to go first or do you want me to go first?
I can go first, and with all due respect, I hope to stump you again today.
All right. So for the listeners, we're going to go through some cases of real poisonings. They might be fatal. They might be something else. The goal of this is for us to understand the differential, what somebody would be thinking about to rule out when you hear somebody come in with these types of symptoms so that we can identify the next poison patient faster and get them some treatment that might change the outcome from fatal to not fatal. And the only rules are really no giving away what the poison is. And if there's a specific antidote that would only be used for that drug, you can maybe say there's an antidote, but try to censor it a little bit. Okay. I am ready when you are.
Okay, so Ryan, you have a 40-year-old female patient who presents to the emergency department with diarrhea, abdominal pain, and anuria 48 hours after performing a rectal enema using a blue powder.
Okay, what? This is a lot of information. Blue powder is nickel. So this might be nickel again. Because when you see blue, there's a lot of color differentials in toxicology. Bordeaux's something like, is this a word? Am I saying that vineyard sprayer's lung?
Mm-hmm.
That's nickel, right? Am I crazy?
That's copper.
Copper, shoot, copper. Thank you. Okay, yeah, there we go. Because copper was a fungicide they would use, and then, yeah. Okay, diarrhea, abdominal pain. Well, that makes sense. You put a blue powder in your GI tract. Anuria. Okay, it sounds metal, because I have GI plus renal injury, so it sounds like maybe a metal salt, which is a pretty common toxidrome of metal salts. But let's hear a little bit more.
So she, at arrival, is conscious. She's hemodynamically stable. She's noted to have this abnormal color to her urine that was port wine. But 6 hours into her observation period, she develops hypoxic respiratory failure, a theme here today. Her oxygen saturation drops to 75%. She does improve a little bit with oxygen, but not quite enough. So they get an ABG on her, and her pH is 7.18. Her PaO2 is 70. Her PCO2 is 30. Her SpO2 on the blood gas is 99%.
Okay, so this is some kind of methemoglobin inducer. I have a PaO2 of 70, so I'm not hypoxic.
Hey listeners, it's me, Toxo, Ryan's superior robotic counterpart. I'm stepping in because Ryan is hunkered down deep in the methemoglobin part of his brain and, as usual, forgot to explain how he got there. So I'm here to provide the context he never actually says out loud to keep the audience up to speed. Yes, I am the real hero. I know. Ryan was keying in on what's called a saturation gap. The pulse ox, that little red light thing you wear on your finger, says the oxygen saturation is about 75%, but the arterial blood gas shows the oxygen level in the blood is normal. That tells us the blood has oxygen. The problem isn't a lack of oxygen. It's that the pulse oximeter is malfunctioning. Here's why. Pulse oximeters shine 2 wavelengths of light through hemoglobin and measure what reflects back. One wavelength is tuned to deoxygenated hemoglobin, 660 nanometers. The other is tuned to oxygenated hemoglobin, 940 nanometers. The device assumes those are the only 2 options. Now enter methemoglobin, the form hemoglobin takes when its iron gets rusty after losing an electron. This altered hemoglobin reflects light at about 635 nanometers, which is very close to the wavelength the pulse ox uses to identify deoxygenated blood. So the monitor gets fooled. It mistakes that reflected light for deoxygenated hemoglobin, even when oxygen is actually present. Because those signals overlap, the pulse ox can't separate them correctly. The math breaks and the reading gets stuck, usually around 70 to 85%, no matter how much oxygen you give. All of that together is a classic clue for methemogloblin.
It's a blue powder. A blue powder? Oh my gosh. Wait a minute. So for the listeners, I'm gonna try this. So everybody knows methylene blue is being hucked hard on TikTok, and all these little scamfluencers are trying to tell you your mitochondria are poisoned, and you need to buy their specific brand of methylene blue to fix them. But methylene blue, we use it to treat methemoglobinemia. That's when your iron loses an electron. It gets rusty. It oxidizes. So you go from iron 2+ to iron 3+. Well, we actually use methylene blue to give an electron back to iron and put it back to its normal state. It's the treatment. But methylene blue doesn't actually start with the electron that it gives to iron. It has to get it from somewhere else. It usually takes it from a store of electrons you have, reducing power, we call it, that's made by G6PD or cytochrome reductase. It doesn't matter. Methylene blue needs to get an electron from somewhere before it can give it to iron. And if there are no electrons around, it will actually take it straight from iron and actually worsen the oxidation. It can actually cause methemoglobinemia and hemolysis in really high doses. So it is possible methylene blue can cause methemoglobinemia. So I'm actually leaning towards that right now. So this is like either, because what is going to cause, copper is an oxidant too, though. Oh my gosh, this is hard. Okay. It's something that caused methemoglobinemia. What, can I get a methemoglobin level?
Yeah, so she initially starts out with 13%, but it rises to 23%. She does get a dose of methylene blue.
Okay, so it's not methylene blue. All right. All right. Then it's an oxidant, which I think is copper. And I do remember once I had a crazy large copper ingestion. It was somebody who had one of those bags that are like ultra bulk supplement. You know, you must use a micro scale and basically like take 1/1,000,000th of this bag of supplements. And of course, nobody looks at that and they just take a spoonful. And they took like a 1,000-fold overdose of copper. And I do remember looking into it and saying, oh yeah, I guess methemoglobin has occasionally been reported. So I'm leaning copper something, a copper enema, because it's blue and they have methemoglobin. Okay. What happened after the methylene blue?
So she has other labs that are reported. Her creatinine is 6.92. This is in our US units of milligrams per deciliters. BUN is 22.7. Her sodium is 128. White blood cell count is 47. Hemoglobin is 12.3. Her CK is 3,427. Bilirubin is 73. She also has an elevated troponin. It's like a high sensitivity troponin, and they noted that it continues to rise. About 48 hours after she gets admitted, she develops anemia to 4.2, and there was no signs of bleeding. And her bilirubin continued to rise, and her LDH was also elevated. Yeah.
Is it selenium? No. I'm just, all right. There's nothing else you could tell me. The Billy's up, the LDH is up, she's hemolyzing. This is a methemoglobin. It's some kind of an oxidant metal, and I think it's copper because of that. The other blue metal is selenium, which is in gun bluing solution, selenious acid, but you wouldn't do an enema of that, and that is super fatal. So I'm going to lock in with a copper something. I don't know what form of copper is blue, but it's that one. And I think that's what they did, a copper enema.
Okay. You ready for the reveal?
Gosh, no, you're going to stump me. But all right, what do we got?
So I did fail at stumping you,
Yes.
Feldman. So this is a case of copper sulfate enema. So I thought I would throw you off just based on the route of exposure. But yes, really good with the fact that it was a blue powder. And so in this particular case, the patient was reportedly using this copper sulfate enema with the thought that it was helping with fertility in some way. And so it was an unusual route for this exposure, but these clinical features are pretty classic, or the hemolysis is pretty classic, and the renal failure is pretty classic. She ends up getting this myocarditis with the copper exposure. So that was the reason for her troponin elevation. And it seems like that's also been reported.
Copper myocarditis. What do you do about that?
Care.
Support that care. I like it. Yeah. It's the metals, they can affect the heart, right? We have cobalt cardiomyopathy, right? I believe you've dealt with some of that in the past before.
Yes.
So, really good case. Copper, the most common place I run into copper is actually in snake fireworks. And that is, take that back. Most common place.
That's I'm thinking of.
Yeah, the most common place I run into copper is in a different thing that you burn, and it's magic fire crystals. So that's how I remember that it's blue, which obviously I don't remember because I said nickel at first and then I recorrected. But yeah, I know it's blue because you throw copper into fire to make a blue flame. Yeah. So if you ever see someone vomiting blue, you should be thinking copper as well as selenium. Really great. Loved that one. Let me go ahead and dig up my files here. Let's see. What did I name this episode? N-carb Dami. There we go. Okay. Do you want to get stumped or not stumped? What do you think?
I don't know. I'll leave it up to you.
I'll start with an easy one. Or not. I don't know. Who knows? All right. A 19-year-old male obtained several of these over-the-counter topical products, extracted the liquid from them, and ingested it. He was found down approximately 30 minutes later. EMS was called. They found him pulseless in a wide complex tachycardia. His cell phone search history included lethal dose of blank search. And on transport, heart rate was between 100 and 140, wide complex. They eventually got ROSC. The patient was intubated, sedated with midazolam. And I guess that's where I'm going to stop for right now. That's not a great description. I'm sorry. That was a bad description. But found something over the counter. It was a topical, and extracted the compound from it and ate a bunch of it, and then was in a wide complex tachycardia.
So there are a lot of things that you can get over the counter that can lead to a wide presentation, but wide complex tachycardia. The fact that it's topical is what's throwing me off here. And so one of the first things that came to mind, also how rapid the patient deteriorated, was Tessalin pearls. So that's benzonatate. So that's like this classic sodium channel blocker. You kind of think of it as like local anesthetic toxicity, and that would cause cardiac arrest and would also cause like CNS symptoms. So the patient here could have been found down because they had a seizure and were unresponsive. Yeah, I'm trying to think sodium channel blockers that are topical products. Diphenhydramine, also another over-the-counter product that, we don't think of necessarily as being super dangerous. 'Cause people sometimes they'll do the Benadryl challenge to try to have the hallucination effects of Benadryl. So you think of it more as like anticholinergic, but in really high doses, it's a cardiac toxin as well.
So I'll give you a little more of the case. He was admitted to the ICU. He was cooled per post-arrest hypothermia protocol. They did actually confirm the drug in his serum, and his urine was negative for TCA, if that helps you at all.
Yeah.
And I know everybody hates urine drug screens. I do think there's some utility in some of these things. And he remained unresponsive to stimulus. Sedation was stopped on day 2. On day 3, he actually had brain death testing. He had cerebral herniation from his cardiac arrest, hypoxic injury. So the arrest, unfortunately, he was down too long and was not able to survive. He did receive bicarb once he was in the hospital for his wide QRS, which did have an effect, it seemed. So, but unfortunately, he passed away due to the hypoxia.
Sure. This is a tough one, Ryan. I also thought, speaking of local anesthetic, this sounds like a local anesthetic toxicity. It's kind of where I'm getting at. And if you were to get benzocaine or something like that over the counter, the oral bioavailability is not that great. So if he ingested it, I just wouldn't expect you to get that sick.
So it was patches that he got over the counter.
Patches.
If that helps you narrow in. Sorry, were you going to say something else?
Oh, yeah, my brain is going all over the place, but I was thinking, it kind of reminded me of when you went to the store and you wanted to see how much loperamide you could purchase. And so loperamide is available over the counter, but again, it's not a topical product, but it's another one that I would associate with QT prolongation and then arrhythmias from there. Okay, I'm going to go back to my local anesthetic thinking and wondering if this patient got a bunch of lidocaine patches. That
would be a ding, ding, ding. Correct. This is on an unfortunate case where somebody figured out how to extract a ton of lidocaine from these patches and consumed them and rapidly went into sodium channel blockade. So you could see obtunded neurologic status and wide QRS tachycardia. There's a ton of lidocaine in those patches. So this does make some sense. Lidocaine patch. Let's find out how much is in one patch. So 4% is the over-the-counter patch. Oh, wait, it says 4%. So we already know how much is in there. It's 40 milligrams per gram. Contains around 700 milligrams of lidocaine within its adhesive matrix. Interesting. I guess it makes some sense because lidocaine is more of a topical. When I think about like fentanyl patches where you have to get systemic circulation, there is like a 25 microgram per kilo per hour patch has like 12 milligrams of fentanyl in it. Something crazy. So that is this is a lot less than that, but I guess it doesn't have to get systemic. It's more just on the skin.
Yeah.
They did check a level here, and his lidocaine was only 3.7, which is not that high, but that's, after the arrest. Who knows what his peak was and all that. So interesting case. Scary stuff out there in the over-the-counter world. You got to be careful. Do you want to do another one?
Yes, let me do my second case.
Okay.
So you have a 57-year-old male who is at a courthouse. He's supposed to get a urine drug test that day. And so they found him locked in a courthouse bathroom with diarrhea, black stool, and a witnessed seizure. A bag of white powder is found on him.
Okay. Diarrhea and black stool and a seizure. The black stool is, why would you be either iron or blood? I'm not sure which. The seizure and white powder makes me think of cocaine or a bunch of other things. But okay, I don't know. I need more information. I'm at a loss here.
So he presents to the emergency department after the seizure, where he is promptly intubated and started on propofol and midazolam. They get labs, and all I have to say is that they note the severe hypernatremia. Potassium was low at 2.7, pH was 7.42, creatinine was 1.1. We do have a urine drug screen that's positive for methamphetamine.
This is tough. So I have a low K, a low potassium, and a high sodium, which are two different differentials in a sense. Baking soda can cause a high sodium and it can cause an alkalosis that will then cause your K to go down. Sorry, what was this pH?
7.42.
That's alkalemic, especially if you just had a seizure. Okay, that was like the first thought I had, and I kind of think that it might be right because you could have a high sodium and then alkalosis will drive your K down. But I'll think of a few other things. I mean, the seizure and low potassium make me think caffeine, because that causes seizures, and then methylxanthines drive your potassium down. Was he getting drug tested because he's a bodybuilder? And this is right before a meet? Oh, no, it was a courthouse.
Yeah, so this is like illegal, like we're dealing with illicit substances.
Yeah. Sodium bromide is another thought here, because sodium bromide is sometimes used by people who are in drug courts because it's not detected and it's a sedative of sorts. Bromism, it acts as chloride and hyperpolarizes your neurons. But I don't think, you would have told me his chloride is 150 if that was the case, which you didn't. What was his bicarb?
So I would say the sodium was 162 and the bicarb, if I tell you the bicarb, you're going to figure out the case, but it's 49.
Okay, I think he took a bunch of baking soda to try to beat a drug test. I think maybe he was trying to alkalize his urine. If this is right, I'm feeling proud of myself. but
I think you got it correct.
nice. Wow, the black stool is kind of a misnomer. It's white. It's a white powder.
It's a white powder.
Okay.
Yeah.
All right.
So this is a case where the mom says that the patient, just like you said, was attempting to beat the drug test by ingesting a bunch of sodium bicarb. And so people will sometimes do different things to try to beat drug tests, like super diluting their urine, trying to change the pH. But they do validity testing on as part of the lab testing for these urine drug tests. So it is not a worthwhile thing to do, I would say.
Unfortunate. That's just an unfortunate product of our societal system, and I don't love it. But interesting case. So yeah, in your blood, you like to tightly regulate hydrogen. If you drop hydrogen significantly with bicarb, your body will pump hydrogen into the blood and pump potassium into the cell because you have to keep net neutrality. So one positive goes in the cell, one comes out. And that is how you get hypokalemia from alkalemia. Wow. Good one. Okay, I got one more. This one is probably a stumper. I'm just going to let you know, but maybe not. Maybe not. I just saw it. I haven't seen this in a while. All right. There's kind of a clue here. A 30-year-old female ingested this blank.
Okay.
And then the following day, about 20 hours later, presented to the emergency department, reporting her self-harm attempt. Vitals were normal. So blood pressure, heart rate, SATs, everything looked good. Temperature was normal. Labs were all normal. Potassium was 4.5, chloride 108, bicarb 25. Serum Tylenol, ethanol, and salicylate not detected. Over the next several hours, despite presenting completely alert and oriented, she developed progressive neurologic decline. She complained of a severe headache, vomited, then had a seizure, was intubated. A CT showed cerebral edema. She was admitted to the ICU, and repeat imaging showed persistent cerebral edema. And on day 4, she was declared brain dead due to her devastating neurologic injury. And I will give you a hint. This was a rodenticide.
That was where I was. My brain was going towards bromethylene when you started the description. Yeah, the delayed effects yet again took me down that path. And so if we're talking about rodenticides, think about superwarfarins. There was this potential delay with that too. Did she bleed into her brain? But you would have told me she had like a large intraparenchymal hemorrhage.
The CT had no bleeds.
Yeah. But yeah, so some rodenticides are kind of superwarfarins, and they would just cause you to have very elevated INR and hemorrhage and bleed. And that's kind of how you would have toxicity. Some rodenticides are cellular asphyxiant that will cause you to really have more of a rapid course in terms of your deterioration. Phosphines is a great example. Bromethylene, if I recall your lovely paper on bromethylene, Dr. Feldman, it's an uncoupler, right?
It is an uncoupler.
But effects can be delayed. It sounds like from your research, most people that have these kind of exploratory exposures to bromethylene do okay. But if this was an intentional ingestion and you take enough, I could see it causing significant damage. So that's going to be my vote, bromethylene. That's where I'm going with.
That would be very correct. Not even close. Wow. I thought it was a stumper and you just knocked it right out of the park. Yeah. I saw a fatality reported this year and it really jogged my, I haven't thought about it. For the listeners, bromethylene is I don't actually like it that much, but it was maybe the first tox paper I ever wrote. So I feel somewhat bonded to it. But it is terrifying because it's one of these triage problems we run into. Bromethylene itself, it's not the rodenticide. It's a pre-rodenticide, I guess you would say. You have to metabolize it into norbromethylene, and that is what is the uncoupler. And obviously, uncouplers are very dangerous because we have no antidote for uncouplers, really, not anything functionally in clinical medicine. So when you get sick, it's one of those ones where you go, okay, well, you're either going to die or you're not. There's very little I can do. It's a lot of supportive care. Fortunately, deaths are super rare. But when I saw this, I was like, oh. And it's scary because it's a delayed onset toxicity. So you can really get yourself into trouble because there's actually a case report of a patient getting discharged to psych, and then 17 hours later, they develop cerebral edema, and then they actually die because they have a seizure at psych where they're untreated. So you really need to try to get a good history of what the patient ingested when it comes to rodenticides if you want to triage them appropriately. And I just thought it was a good case to talk about. So great job. You knocked it out of the park.
So we failed at stumping each other, but they were all really good cases to talk about.
Yeah, I thought they were really good. Wow. I'm going to be riding that high, getting that sodium bicarb for days. Oh, and for the listeners, I had brought up that Dami's lidocaine patient was tricyclic antidepressant negative on the urine drug screen, which helped us narrow in on what the agent might be. Did you want to talk about that, Dami?
Yeah, so we guessed diphenhydramine, which will actually make your urine TCA screen positive. And so it's one of the reasons we talk down on urine drug screen a lot in talks, because those immunoassays that they use are so nonspecific. And so if you have a substance with a structure, which is what the immunoassay is designed to identify, you have another substance that shares enough similarities structurally, you can have this cross reactivity, which will lead to a false positive. And so if you have a lot of sodium channel blockers actually have the shared ring structure with TCAs, and so they will tend to trigger your TCA positive. So diphenhydramine is one that we know does that.
Right. So if it was positive, I'd probably think, oh, okay, maybe this guy took diphenhydramine. Now, a negative obviously doesn't mean it wasn't diphenhydramine, but yeah. Excellent. Well, we have exactly several minutes if we wanted to try to tackle some questions. Are you up for doing a couple questions? I love it.
Let's do it.
I wanted to actually bring up one that a listener sent in before we dive into the other. And I don't know that we have an answer for this question, but I find it really interesting. So I thought it'd be a fun one to bring up. This one comes from listener Paulina Frost. And they were talking about GLP-1s and toxicology, which has been kind of a hot topic, right?
Yeah, very much so.
Basically, GLP-1s plus anything means hot topic. Like, no, everyone's trying to figure out how to deal with the changes in society GLP-1s are bringing along. I even saw an article recently, like GLP-1s are saving planes money because everyone's losing weight.
They're like the magic pill to everything.
Yeah, apparently.
Magic shots, I should say.
Yeah, although now there's some pills. Okay, this one says, "Hi, Ryan. I've been listening to the podcast for the last few months, and I'm a fan. I'm currently in my first semester of my master's in public health in industrial hygiene, which is super cool. Industrial hygienists are like I don't know what the term is, but they're kind of like the Wizard of Oz. They know all of the specific ILDHs and all the acronyms that are always terrifying. Yeah, so it's super cool. It's a cool career field. And she says, when we were learning about where toxins are stored in the body, an interesting question came up in class. How does rapid weight loss from GLP-1 medications affect the release of toxins stored in adipose tissue? What are the potential implications of this on a population level where the use of drugs like Ozempic is sharply rising? I was not able to find any research on this, and I'm wondering if this was even considered during pharmaceutical development process. If you know any researchers working on this, please let me know. Additionally, I would love to hear an episode with a guest who is an occasional toxicologist. I assume that means occupational toxicologist. I'm what you would call an occasional toxicologist. And she says, thank you, Paulina Frost. And I just thought this was a really unique question. And what have you heard about in terms of acute toxicology? Anything come to your mind when we talk about how GLP-1s are changing things a little bit?
I mean, we know that they can change some of your pharmacokinetics that we rely on for triaging people. And so, the really classic one is that delayed absorption that can happen. And so, we rely on those pharmacokinetics to say, we expect the peak effect to happen at this time because we know that by this time, most of this drug would have been absorbed. But when you're dealing with something that significantly changes your GI kinetics, that can be tough. So that's one issue.
Yeah, that's the big one. Like, should we be giving charcoal later if you see Ozempic on their list?
Right.
Because they might have very delayed absorption. Not later overall, but like, is there a longer window that we can give charcoal in on whole bowel and all those things? I mean, we've seen the toxicity of the compounded stuff, but a lot of it is just like, well, or for example, line crossers with Tylenol in certain scenarios where if you ingest Tylenol with a anticholinergic or an opioid, we'll actually check 2 Tylenol levels because we know you have really delayed absorption. So we'll check just to make sure you're not still absorbing and you cross the treatment threshold. And there's some who have said we should probably do that for GLP-1s as well, if you take a big Tylenol overdose in GLP-1. But I haven't thought about the other side of what Paulina was talking about, which is what about all these things that are stored in our tissue? And I'm not overly concerned, I guess, about like all the microplastics that I might be releasing and all this stuff. But here's what I thought was really interesting. And I bet you this will come up as a legal case one day. THC, in a chronic THC user, you have a kind of chronically detectable serum level of THC because you have such high fat reservoirs and it's constantly leaking out. And if you go online, you'll see it in the people trying to pass drug tests, which goes back to your case. They'll be like, if you smoke or if you use a lot of marijuana, do not work out the day of your drug test because you don't want to release any THC from your fat stores. And there's actually chronic users who walk around with levels greater than 5 nanograms per milliliter, which is greater than the level that has been determined to be the impaired level for driving for legal states. But they're just walking around with it, and they're not impaired necessarily. It's just the level that's leaching out of their fat tissue. And if you suddenly reduce your fat tissue content, that drug is going to have to go somewhere. So I bet you, nobody's measured it, because why would they? But this might come up in like a legal case. If someone just started Ozempic and they're a chronic THC user, I bet you that their THC concentration goes up significantly. And if they get in a car accident and they check their serum level and say, well, you had an elevated THC. Well, is that from the use of THC or is that from just starting a drug that immobilizes it from your fat tissues where things could get really, really dicey?
This podcast is going to end up being cited.
Yeah. I don't know. Anyways, the short answer is probably, I don't think anybody has that answer. I have not seen any research, but I think it's an interesting question. I could see some areas where this could become relevant either in the forensic field and in the tox field. Anyways, okay. That was just something I thought was worth chewing on. Did you have any other questions that you pulled that you wanted to go over? Otherwise, I could pitch one to you too.
We have a question from Reddit here. Do you want to hear about it?
Yeah, I'll do my best.
Okay, so the question goes, why do I get muscle spasms in my hands after taking a lot of Lyrica? Basically, when I take Lyrica or high doses of Lyrica, my hand spasms. It happens when I mix Lyrica with other drugs. It's worse. So example, today I took 600 or 800 milligrams of Lyrica with 100 milligrams of baclofen and getting frequent spasms.
Hello, listeners. It's me, Toxo. I know I've been awfully quiet this episode, but for once, Ryan got most things right. Ryan realized he missed an important safety note. The doses of Lyrica and baclofen we're talking about are huge. Not toxicologist stares at the ceiling with jaw open huge, but absolutely not doses to approach without direct supervision by a healthcare professional. And I mean, obviously these are prescription drugs, so they shouldn't be taken at all without a healthcare professional. But like also, don't take doses this high unless someone with a medical license has very intentionally told you to do so and is watching you closely. Okay, that's all. Don't make bad decisions, people. Let's get back to it.
Yeah, this is a really great one. And the reason Dami has this question is because I asked her to ask it to me. But I was on Reddit Ask Drugs and just kind of reading some of the things in preparation for this episode. And this question, Lyrica and muscle spasms, reminded me of a case that I saw in the ER where a patient was having new onset hand myoclonus. They were on a ton of different drugs. So it was actually really hard to figure out which one, but they were on a fairly large dose of gabapentin. And I kind of was doing some research and I was like, actually, I think it's the gabapentin. So it turns out gabapentin and Lyrica, a lot of people think of these as sedatives and muscle relaxants, which they are, but they also can have what's kind of like a disinhibitory effect on your motor system, where it alters the inhibitory and excitatory balance kind of in your motor system and turns off the motor control circuits. And this allows your motor control to go excessively sending out signals and cause myoclonus. And actually, myoclonus has been reported with both Lyrica, baclofen, and gabapentin in a fair amount of case reports that all seems to resolve after you stop the medication. Of course, there can be other underlying reasons why you might have myoclonus. It gets really tricky with baclofen because it's often prescribed for spasticity. So then you have to parse out what's underlying disease versus a new drug effect. But I just think that question is a good reminder that that's actually kind of an expected effect in a certain small amount of the population who's having this sort of disinhibition of their motor control units. And yeah, that's why it's happening, I believe.
That's really interesting. Yeah, I don't think I've actually thought about the fact that you can have myoclonus with gabapentin. So that's helpful for me. I might have missed some cases in the ED, not knowing what was
Well, it's
caused.
rare. It's definitely rare. And I bet, it's the kind of thing where you'd want to rule out all other causes first. But yeah, it's something that should be on the differential. Yeah. Good question. And thank you. Did I have a question I was going to ask you? I'll tell you what I didn't do is send you what the question was going to be about, which I meant to do. Oh, I'm just going to read some of these to you because I think they're a little bit nuts. So these are my honorable mentions that I learned some things from on reddit.com/askdrugs. What are ketamine needles? Somebody says, what does ketamine needles mean? What exactly are they referring to? Is it literally injection needles or is it slang, like a brand name?
I don't think I've ever heard the phrase ketamine needles.
Neither had I, but this was the actual answer from one of the users. So let's take this with a grain of salt. It's the shape the crystals grow into. Apparently, if you buy ketamine as a crystal, it's tiny little needles, which I guess does make sense. Anyone, if you work in an emergency department, go look at your mannitol vial. It's going to be crystallized into tiny little needles. So apparently there is a form of ketamine people are buying, which is the crystal form, and it is tiny little needles. I didn't know that. Here is another question that I thought was really crazy that people just don't know what they're doing. This question was, gonna try Xanax ethylbromazepam for the first time. And they say, just wondering how much I should take and if I should expect any withdrawal. This is Xanax that I purchased from Bleep Reality, if anyone has experience with them. What do you think about that, Tommy? Does anything out here stand out as a red flag to you?
The fact that they're calling Xanax ethylbromazepam is a red flag.
Yeah, that's not Xanax.
Expecting withdrawal. Well, the thing is, depending on what you're getting on the street, you don't know what you're getting. And so you might have symptoms that are kind of the opposite of what you're seeking. So you might have more excitatory symptoms than the inhibitory symptoms that you're seeking when you're taking Xanax. If you get some novel psychoactive substance, that's like not what you'd expect. But withdrawal, we really would worry about if you're taking it chronically, if you're actually taking alprazolam.
Right. Yeah, so that's a great point to bring up. It's like, okay, well, no, a single acute use doesn't usually lead to withdrawal, but who knows what's actually in there? You might be taking this that's spiked with like methylone or something like that, and you're actually going to get a stimulant toxidrome. But I thought that case really highlighted, that question really highlighted that people just don't know what they're doing out there either, which is kind of scary because these are dangerous drugs to be messing with. Xanax is not ethylbromazepam. It is alprazolam. And ethylbromazepam is definitely a weird research chemical that you should not be putting into your body. But okay. And then I think this highlights, this isn't a question, but I thought this was interesting. that one of the posts I came across was, yeah, I have massive bottles. I used to keep 500 Xanax at a time in. I have 15 to 20 of them. How do I get the pill dust out of the bottom? I've licked the upper parts clean. And then they go on to say, I don't know what benzos they are, either fluelprazolam, bromazolam, or chlorbromazlam. I should probably put a tiny amount of water in each of the bottles and swish it around and take them all at once? Question mark?
The answer.
The answer on Reddit was, sir, you have a problem. And yes, this is problematic drug use. If you're trying to figure out how to lick the bottom of your Xanax bottle, which is not Xanax.
Again.
This is so problematic. This is what scares me. I don't know. What would you, if a patient asked you this, Dami, what would you recommend?
I would say, sir, you have a problem.
And they do. And you know what? I hope that we have the right systems and care in place, that they are able to get connected, because this person they sound like they're really going to need some help from a healthcare professional getting off of this if you're trying to lick your bottles clean. Anyways, just another thing we should reflect on as we try to build better systems in the future. That was all I had. It's not really questions. I kind of failed on the question part. That was my bad, Dami. But
no, this was fun.
That was all I had for this episode. I really, really enjoyed learning about nickel carbonyl and some great cases and a couple of quick internet questions at the end. Any final thoughts that you wanted to share with the listeners before we close out?
I just really, really happy to be on podcast. I hope Dr. Feldman will have me again sometime.
Anytime. Dr. Damilola Idowu Ellsworth has a standing invitation at any time. And also, if you guys didn't get your fix here, you can catch Dr. Idowu Ellsworth at the Acute and Intensive Care Section Symposium. She is the current Acute and Intensive Care Chair for the North American Congress of Clinical Toxicology.
With some really big shoes to fill.
Already doing a fantastic job in it. So I'm excited to see what you have cooking up for the next few years for AIC. I'm looking forward to some good webinars. We definitely have to do this again.
Thank you for having me.
What a fantastic episode. Thank you so much to our guest, Dr. Idowu Ellsworth, for joining today. We covered a truly terrifying inhaled toxin. Why would you combine nickel with 4 molecules of carbon monoxide? I don't know. But don't breathe it in for very long, or there's not very much we can do except try to put some disulfiram down an OG tube, because you are very likely to be intubated. Don't forget about your other toxic time bombs like bromethylene or phosgene. And we covered some unique toxidromes today, like sodium bicarbs, hypernatremic, alkalemic hypokalemia, as well as some good reminders not to lick your lidocaine patches. All right, that'll do it for this episode. If you liked what you were listening to today, one thing you could do right now to support us is rate the show wherever you're listening to podcasts. Even leave a comment about what you like or don't like. It helps us make the show better for you and reach other people interested in learning about toxicology. You can always follow the show on social media, where we do release information about all new episodes. We are on Blue Sky at empoisonfarmd.bsky.social, on Twitter at empoisonfarmd, and the show is at @labpoison, on Instagram at tox_talk, and on Facebook, The Poison Lab. Even better, if you want to hear about updates from the show, go to our website, www.thepoisonlab.com, and sign up for our newsletter so you can get messages straight from Toxo, alerting you about every episode with a freshly made summary and even providing some extras. So far, current subscribers have gotten news flashes about emerging psychoactive substances in the drug markets, mnemonics for toxic mushroom games, and more in-depth dives into some of the poisons we talk about. And there might be some hints of a blog coming soon, so it's a great place if you want to stay informed on trends in toxicology. And remember, if you want to help support the ongoing costs of show production, you can provide support at www.thepoisonlab.com/support. And as a thank you, you'll get access to the supporting membership feed, which has bonus episodes, more in-depth discussions, and gets you put on the list for things like giveaways when we have extra merch. Other ways you can support the show: buying a copy of Poisonous Fungus Among Us, which you can find on Amazon, or checking out the game Gotta Pick'em at www.gottapick'em.com. Lastly, if you had something that you wish we would have talked about, or you want to let us know we said something wrong, or just share a tidbit about how something we said resonated with you, you can reach the show anytime at toxtalk1@gmail.com. That's toxtalk1@gmail.com. And we love getting messages from the listeners. I promise you, they all get read, even if we don't have time to respond to each one. Okay, that'll do it for this episode. Thanks for listening, and I hope we can catch you next time. Music in this show was from Pixabay, featuring artists Driver Silver, Lexan Music, Vera Miller, and Rocco Garibaldi. Hey Toxo, can you play us out? You can use your old voice module if you want.
The information on this show is for educational purposes only and should not be interpreted as medical advice or treatment recommendations. Contact your doctor for health questions or call your local poison center at 1-800-222-1222. This show is owned by Clinical Toxicology LLC. It's haphazardly written, produced, and somehow hosted by Ryan Feldman, who promises he's trying his best. The views and opinions expressed on this show are solely those of the host, and in no way reflect the opinions of any organizations affiliated with him. They probably wish we'd remind you of that more often. Okay, that's all for now, Toxicologists. Don't forget to give it a share with your nerdy friends. Cheerio, mates. See you next time.